Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonny Abbara, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Abbara. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
RSNA 2020 is coming to you. We invite you to take part in this year's all-virtual event, November 29th through December 5th. We're committed to providing the same outstanding programming that you've come to expect from RSNA in a variety of digital formats. All RSNA members get free premium access to RSNA 2020, which includes the following: CME opportunities, on-demand programming, and extended access to meeting content through April 2021. Non-members can register at a special rate until October 1st. Register now at rsna.org/annual-meeting. Hello, everyone, and welcome back to another episode of the Radiology Cardiothoracic Imaging podcast. My name is Praveen Ranganath, and I will be your host. On this episode, we explore a recently published review in the August-September issue of the journal focused on CT imaging of intrapulmonary lymph nodes. The featured publication is titled Typical CT Features of Intrapulmonary Lymph Nodes, a Review. This review comes to us from our colleagues in the Netherlands and Germany. Dr. Anton Schreuder is the first author, and Dr. Matthias Prokop is the senior author. Now, I anticipate that this review will resonate with many of our listeners out there because so many of us frequently encounter pulmonary nodules in our practice. And I know that many of y'all have all sorts of bookmarks and dictation macros to recall those often forgotten guidelines on nodule characterization and nodule follow-up. First, let's review some terms. An intrapulmonary lymph node refers to a lymph node in the pulmonary parenchyma, excluding peribronchial and mediastinal nodes. That's primarily a pathologic term. A periphyseal nodule is the CT presentation of an intrapulmonary lymph node. So now I ask you, what are periphyseal nodules supposed to look like? Should we be following periphyseal nodules? Are these periphyseal nodules always benign? How often do we mistake a cancer for a periphyseal nodule? Well, I have spoken with the lead author of the review, Dr. Anton Schreuder, about the answers to these questions and more. Make sure you get your hands on this review in the August-September issue of the journal. Now, let's jump into my conversation with Dr. Schreuder. All right, welcome back, listeners. I have with us lead author of our featured paper, Dr. Anton Schreuder. Anton, welcome onto the podcast. How are you doing?
Hi, Praveen. Thank you very much for having me. Very happy to be here. Considering the current world situation, I'm doing quite well.
Perfect.
I hope you are too.
Yeah. Safe and sound, as safe as we can be. Thanks for asking. Now, Anton, tell us a bit about your background. Where are you from? Where have you trained? And where are you currently?
So I am half Dutch and half Thai. For the past 12 years, I have been living in the Netherlands. That's also where I obtained my medical degree from Leiden University. And right after obtaining that degree in 2016, I started working as a PhD student in the Diagnostic Image Analysis Group. That's in the Radboud University in Nijmegen. And I am still there. I am finishing off my dissertation at the moment. And I think also relevant to this conversation is the topic of my dissertation, in that is what mainly involved me creating risk prediction models for in the context of lung cancer CT screening, where we extract information from CT scans in order to improve the workflow of the screening process and to make the screening more personalized for the participants. At the moment, I have decided to focus more on research careers. So Hopefully, I'll be starting as a postdoc soon. But I think it is also important that I mention here that I am not in training to become a radiologist, which you might have otherwise expected based on my lead authorship of this review article.
Excellent. Well, hey, congratulations and all your successes and all your accomplishments. And in particular, congratulations on this publication in the journal. To remind our listeners, the publication that's in this August and September issue of the journal is titled Typical CT Features of Intrapulmonary Lymph Nodes, a Review. So once again, congratulations on the paper. It's extremely comprehensive, it's very readable, and it's extremely relatable. For essentially all of us imagers out there, we frequently encounter these pulmonary nodules, so this topic is widely applicable. Before we dive into the nitty-gritty of these nodules and the review itself, could you talk to us about why it is so important to characterize intrapulmonary lymph nodes accurately?
Yeah, so, well, thank you very much for your compliments. I'm glad that the paper is readable, and I do hope that it will help a lot of readers on this topic. Intrapulmonary lymph nodes are essentially benign entities, right? Benign nodules. So the reason that it is important that we learn how to characterize these on images is because if based on one CT scan, we can already reliably say that a certain nodule is an intrapulmonary lymph node, then it makes any follow-up scans completely unnecessary. And the reduction of follow-up scans is, of course, very important because that not only leads to reduction in medical costs, but also reduction in the workload of radiologists and technicians. And of course, it is better for the patients because it not only do they not have to come back for another scan, but it's a very scary thing. It's high anxiety for them to have to undergo this waiting process of whether the thing that was seen in their lungs was actually lung cancer or not. I mean, also, if you consider this in a larger scale, that every year more and more medical images are being made and the technology is improving, meaning that we can see smaller objects in a higher resolution. The combination of these two things, let's take lung cancer screening as an example. It's a hot topic and it's being implemented in various countries at the moment. More CT scans of the chest will reveal more people with all of these nodules. And of course, the vast majority are benign nodules. But if we say all nodules above, say, 6 millimeters have to be followed up to be 200% sure that it is not lung cancer, it is just not economically feasible to do this. We do not have enough radiologists. We do not have enough money. We do not have enough CT scanners to do all of this. So a reduction, especially if you're thinking of hundreds of thousands of CT scans, a reduction of just a few % of the follow-up scans can make a big difference. And this characterization, this identification of nodules as lymph nodes can play a big role in reducing the number of follow-up.
Yeah, Anton, I could not agree more. This is an extremely practical approach to something that has international impact, particularly, as you mentioned, more and more countries around the world are implementing lung cancer screening programs. As so many of us imagers are taught, these intrapulmonary lymph nodes are largely benign and require no further follow-up. Are the major societies in alignment with this too? Do they agree with this assessment as well?
Yeah, so the short answer is yes. And I think maybe at this moment, something I forgot to mention in my previous answer is that we have not yet introduced the periphyseal nodule, which is essentially what the CT equivalent of the intrapulmonary lymph node is. Intrapulmonary lymph nodes have certain features, but without the actual pathologic confirmation, we cannot be 100% sure that they are indeed lymph nodes, so we call them periphyseal nodules, or PFNs, as I like to say. That is also what guidelines refer to them as, PFNs, periphyseal nodules. As I was saying, the major societies do say that periphyseal nodules do not need to undergo additional follow-up. So this includes the British Thoracic Society, the Fleischner Society, and the American College of radiology, which created the lung RADs. And so this means that this applies to screening and non-screening settings as well. Maybe I also mentioned that there are a couple of other societies, namely the American College of Chest Physicians and the National Comprehensive Cancer Network. Those two do not explicitly mention periphyseal nodules, but for the American College of Chest Physicians, their latest guideline came out in 2013, so you can say that that's a bit outdated, and probably their general opinion has changed since then. And as for the National Comprehensive Cancer Network, they state in their guidelines that, so their words, not mine, they are harmonized with lung RADs. So I interpret that as being that they agree with whatever the lung RADs publishes, and well, the lung RADs says that we should not follow up, have additional follow-up for PFNs. So I assume that they would agree with this statement.
Okay, very good. So it sounds like some of the major academic societies have either addressed it directly or indirectly in terms of being on the same page. We should not be doing additional follow-up for these periphyseal nodules. Now, how common are these periphyseal nodules, both in your experience as well as what's been reported in the literature?
Right. So I will start with in the literature, because there's quite a high variance. This variance ranges from 1% prevalence to about 66% prevalence. And well, the main reason for this is probably because it's an issue, because some of the studies which mention these numbers, they do not actually mention the methods which they use to come up with these numbers. So they do not mention, for example, the exact criteria that was used in order to classify nodules as PFNs. And on top of that, they do not mention how many radiologists participated in this classification process and who these radiologists were, because we also know that there's a huge inter-reader variability of classifying nodules as PFNs. So those two factors play a role in what is reported as the prevalence of PFNs. So the lowest prevalence of 1% that was reported in the PAN-CAN cohort, the Canadian lung screening cohort, whereas the highest prevalence of 66% out of all nodules was in a small Dutch pediatric cohort.
Oh.
So what we also did, of course, there are 9 studies in total which mention the prevalence of PFNs. So we pooled the results together, and with that we come up with a pooled prevalence rate of about 12%.
Okay.
Personally, I think that this is not a good estimate for the reasons I mentioned previously, and I think it's a too low of an estimate. From my research experience, I expect that most radiologists would classify at least 1 out of 4 nodules, 1 out of 4 pulmonary opacities to be PFNs, and that's a low estimate.
Yeah, I think I completely agree too. Just anecdotally, those numbers agree with what I've seen. I presume that our listeners would agree with you too. I wonder if there's some heterogeneity in terms of populations, not only geographically, but also in terms of age. Excellent. Let's get into the typical imaging features of those periphyseal nodules themselves. In your review, you note that the literature doesn't quite have a uniform definition of what PFNs are on CT. Could you go into this a little further?
Yeah, so I think it's time then for a short history lesson.
Yeah.
The PFN was first coined in 2010 by the group An et al. And their main goal was to create this new nodule classification system, which if you would classify a nodule as a PFN, then you can guarantee that it is benign. And that's what they showed, and that's also what a few studies have confirmed. So that's a good thing. So the criteria that they used for this was actually quite simple to begin with. PFN had to be a non-calcified solid nodule with well-circumscribed margins, and they should be within 5 millimeters of a major, minor, or accessory fissure. And that's where the term PFN periphyseal comes from, of course. In this case, no other criteria were necessary for a PFN. Now, 2 years later, De Hoop et al., they came up with the second study focusing on, well, building up on the concept of a PFN. And here they wanted to show that a nodule which had been classified as a PFN, if in a follow-up scan would be shown to grow or shrink, that regardless of this, it would still be a PFN and it would still be benign. So growth or shrinkage of a PFN does not mean that it is suddenly malignant. No, it is still benign. So that's all great and everything for the concept of a PFN, except already they use a significantly different definition of what PFN is. So firstly, they now include shape requirements, and that nodules to be a PFN had to be oval, lentiform, or triangular in shape. And on top of that, they created two subdivisions of PFNs, the typical PFN, which had to be attached to a fissure, and the atypical PFN, which could be located anywhere else in the lungs. So yeah, that's already quite a big change from the original definition of a PFN. To be fair, I think this definition was, well, it is the most popular definition to date. They have a very nice figure, which has been republished in very many articles, including our review article. So it is, yeah, it is a very simple but very informative figure on how a PFN should look like. And well, yeah, so there are a few studies which used the definition by De Hoop et al. To measure the prevalence of PFNs in their studies. But until 2018, nothing drastic happened. But then in 2018, two new studies came out, one from Metz et al. Exactly, and one from our group, where I was also lead author. And so these two new studies had two new definitions for PFN. I'm not going to go into the exact details of what these criteria were, but I will mention that what these new definitions added was that you now not only had to consider the relationship of the nodule to the fissure, but also its relationship to the visceral pleura. And that's actually also more in line with what is reported in the literature on intrapulmonary lymph nodes, because they always mention relationship to the pleura, and there's no mention of relationship to the fissure. So the whole idea of being next to a fissure, which was the original idea, that's kind of just an idea which does not have a solid basis. But in any case, so these two new studies now include relationship to the pleura, and our study also now mentioned you should look for the presence of extending linear densities, which are just these thin little lines extending from the nodule. We do not know exactly what these are pathologically. There are several ideas, but perhaps I'll go into that later. All in all, there are right now 4 different definitions of what a PFN is.
Oh.
And well, now if you include the review article, there are 5, which is a bit annoying, but we do hope that the review article's definition is more of a consensus definition, and we hope that this will be used by most people from now on.
Well, perfect. With regards to that consensus definition, how would you summarize the overall definition of what a periphyseal nodule is?
Yeah, first of all, I mentioned consensus definition. This is, of course, based on a very small group of so-called experts, including myself. So it is very prone to change with new developments. There are, I think the most agreed on criteria for a PFN that, well, nobody will oppose is that a PFN should be non-calcified solid nodule with smooth, well-defined margins. And there's also very clear agreement on the shape that a PFN should be, in that it should be oval, lentiform, triangular, or polygonal. And then what comes next is a bit more well, open to discussion. Again, I mentioned that you should look at the relationship to the pleura and the fissure, so both of that. And according to literature, almost all intrapulmonary lymph nodes are within 15 millimeters of the pleura, the visceral pleura. So that should definitely become a criteria. And on top of that, the overwhelming majority are located in the middle or the lower lobes. This has to do with the lymph drainage in the lungs. So I think that those are the main criteria for what you should look for classifying a nodule as a PFN.
Excellent. And just from a practical perspective, do we typically use these criteria on axial imaging alone? Is it on axial, coronal, and sagittal imaging, on multiplanar imaging?
Yeah, so that's a very good question. I was going to come up upon that if you had not. So this is based on the transverse plane mainly, which is a huge limitation in my opinion, because, well, all studies included in our review article only gave a two-dimensional shape to each nodule, which of course is ridiculous if you think about it, because a nodule is three-dimensional, and which means that if you just by pure chance see a nodule with a slightly atypical shape, then you automatically do not classify it as a PFN, whereas if you would have looked at the other two planes, then probably, possibly it could have shown more typical shapes. And, well, the opposite can be true, that a nodule from one plane may look very typical, but then look very abnormal from the other two planes. So, but in that case, you would be classifying possibly a malignancy as a PFN. So that's very dangerous. So I also vouch for the fact that when trying to classify nodules as PFNs, always look in all three orthogonal planes.
Excellent. And I think that's kind of segueing into what I next wanted to ask you. Our listeners will find it very important to not mistakenly classify a cancer as a periphyseal nodule. So could you talk about some features that would push us away from a diagnosis of a PFN and towards something else?
Yeah, so the most prominent red flags that you should look out for are nodules which are spiculated, as I mentioned, which have an irregular shape. And with this, I do want to mention that we considered spherical nodules also to be, well, you should not classify these as PFNs, because we believe that although you can have lymph nodes which are spherical, there are also many malignancies which, because they just have unrestricted growth, can also appear spherical. So it is just not specific enough. So do not classify spherical nodules as PFNs either. Also watch out for nodules which have unclear margins, nodules which cause retraction of the pleura or the fissure, and which do not appear to be influenced by other structures. As I also just mentioned, nodules in the upper lobes should be watched out for, because not only do most lymph nodes occur only in the middle or lower lobes, but more malignancies occur in the upper lobes. So that's two reasons why you should not do that. And finally, also with the thanks to development of CT technology and being able to look into details, we also now know that most lymph nodes do not have arterial attachments to them. They can have venous attachments, they can have no attachments, but these extending linear densities that I mentioned before are therefore veins. We know that adenocarcinomas can have venous and arterial attachment to them. So the safest bet is to say any nodules with an arterial attachment should not be classified as a PFN, because there is too much risk that it is indeed a cancer.
Anton, in your review, you have provided an excellent decision tree flowchart to provide clinicians a safe and structured guidance on how to approach potential PFNs. Could you talk about how you created this flowchart and how it should be used?
Yes, so you are absolutely right. It's a nice flowchart that we ultimately came up with. It was quite challenging to come up with this flowchart, especially one which all the co-authors agreed upon. But the fact that we succeeded gives me hope that this flowchart will be considered to be acceptable by most radiologists. So our goal was to find a balance where, on the one hand, we can classify a significant number of nodules as PFNs, But on the other hand, we wanted to keep the risk of misclassifying a malignancy as a PFN as low as reasonably possible. So if you start at the top of the flow chart, you have the detection of a nodule. Then you go through the checklist of whether the nodule is solid, non-calcified, has smooth borders, has no arterial attachment, and has no red flags for malignancy. On top of that, we also decided to add a size limitation in that the nodule should not be larger than 12 millimeters in maximum diameter or 10 millimeters in average diameter. And the reason for this is because we reasoned that size remains the best predictor for malignancy. And it is by chance possible that a cancer will just happen to look very much like a periphyseal nodule, but especially, well, if a nodule just simply gets too big, you should really be double checking it, which is what we recommend. So if a nodule passes all of these requirements, then we go to the next step, which is checking its relationship to the pleura and the fissure. So if the nodule is attached to a pleura or the fissure, then the only other requirement for it being classified as a PFN is that it has typical shapes, lentiform or polygonal, in at least 2 of the 3 orthogonal planes. So I already explained why we should be looking at all 3 orthogonal planes when classifying a nodule as a PFN. I do want to explain why we decided that in this case, only 2 of the 3 planes have to show a typical shape. Because which might seem strange at first glance, but you have to imagine this lymph node, which is being pushed against a so-called wall, where you would expect in 2 of the 3 planes that it does show a typical shape, but in the same plane where it is being squeezed against that wall, the pressure will just lead to a strange abnormal shape of the nodule. And this should not immediately cause you to shy away from the diagnosis of a PFN. Of course, you should always be careful. Of course, you have to consider all other things. But as long as it has in 2 of the other planes a typical shape, then it's probably still is a periphyseal nodule. And then finally, in the case that a PFN is not attached to the pleura or the fissure, you do have to have typical shapes in all 3 orthogonal planes, because in this case, there is no wall. Then in most cases, we expect that the lymph node will have an oval shape in all planes. And then the requirement still is that this nodule should still be within 15 millimeters of the visceral pleura, and it should be located in the middle or lower lobes.
Perfect. This overview of the decision tree is great, and I really recommend our listeners take a strong look at it and implement it into their practice in the future. For you, Anton, do you have plans for prospectively evaluating this decision tree, or more in general, what are your future goals with regards to your work?
So at this exact moment, I do not have plans, but I do think that it is a great research opportunity, probably in collaboration with various groups, to try to validate this decision tree to make sure that indeed it does not lead to a significantly high number of misclassifications of lung cancers. Although I think that a retrospective evaluation is just as good as a prospective evaluation in this case, because we already have, just from lung cancer screening trials, thousands of CT scans from patients which have been followed up for various years, meaning that we can be already certain of the diagnosis of whether a nodule is benign or malignant. And as long as the radiologist participating in such a study is blinded to the outcome, then there is no real added benefit of performing this study prospectively. So we don't have to set up this whole randomized controlled trial setting and have to wait 10 years in order to be able to come up with a conclusion whether this decision tree works or not. We can start it as soon as possible, as long as you set up enough images and we make sure that there are enough participating radiologists. And I think that this decision tree can be validated relatively soon if we would want to.
Excellent, Anton. Thank you so much for your time. I really appreciate your excellent review in the journal, as well as your insight on this important topic. Thank you again.
Thank you very much for inviting me. It was really good to be here.
Of course. And I encourage all of our listeners out there to go out there and get their hands on this review in the August-September issue of the Radiology Cardiothoracic Imaging Journal. Once again, my name is Praveen Ranganath. If you like what you hear on the podcast, please rate, review, and subscribe. We will see you next time.